Okay, welcome everyone to the Pathways to Critical Care webinar series. We are doing a special version this time on medical intensive critical care. I'm joined by an awesome panel of attendees, obviously this time. I'm just gonna go through them in order here. I'm just gonna unshare my screen here really quick so we can get to the actual flow of the webinar itself. Okay, so without further ado, I'm going to go ahead and introduce everyone here. First of all, my name's Matt. I'm going to be the moderator for the session tonight. I am the CCMS AAEM RSA representative for the critical care section itself. I'm very happy to start the second, I guess, iteration of our critical care series here, continuing down the line with SICU next month. So if there's any questions that want to be asked, please use the Q&A or the chat box, and we'll definitely get to those towards the end of the session, okay? However, let's start with our first panelist here, Dr. June Gordon. She is an assistant professor of emergency medicine at Stanford, where she did her EM residency as well, and her critical care medicine fellowship. She currently works in the MICU and EDICU, and she is also the APD of the Critical Care Medicine Fellowship at Stanford. And she's also our chair of the AAEM CCMS. So very nice to have you, Dr. Gordon, and thank you very much for coming. Next, we have Dr. Skylar Lentz. He is an assistant professor of emergency medicine at the University of Vermont. Works clinically as an attending physician in the MICU, ED, and then surrounding community emergency departments as well. His main interests include critical care education, shock, and ventilator management. And he is also our past chair of the CCMS. So again, nice to have you, Dr. Lentz.
Thanks for having me.
And last but not least, we have Dr. Gregory Wu, Assistant Professor of Emergency Medicine and Clerkship Director, sorry, mumbling my words, for critical care for fourth-year medical students at Albany Medical College, where he also works as an EM physician and medical intensivist. Primary interests include COVID-19, where he is the co-lead physician for the monoclonal antibody service, bronchoscopy, and PEs. So nice to have you, Dr. Wu, and welcome to all of the attendees that are currently here.
Great to be here.
Awesome. I kept on commenting about Dr. Wu's background. If you ever join the critical care medicine section meetings, you'll see a different one every time. We were bouncing between Star Wars and Thor: Love and Thunder, I think was the other one.
Yeah, you know, it's like what have I been watching recently? So I've been watching a lot of Andor recently, and this was on my mind.
Andor is great, by the way. That's a good choice.
Oh, I love it.
All right, so let's go ahead and get started here in the interest of time. This is going to be about an hour-long session here. Hoping to finish a little bit early because some of our panelists have to leave to take care of children, etc. So I guess just a very broad question to start out with, and from I guess all three of you, why did you choose the MICU subspecialty from EM? What was it that kind of grasped your attention that, hey, I want to do this for the rest of my life?
Well, I'll tell you what, I'll take the first stab at the question, and then people can laugh at me for my poor reasons. Yeah, when I was a medical student kind of looking for residency, I was actually really kind of trying to decide, did I like kind of the high pace of emergency medicine, quick fixes for quick problems, resuscitations, and kind of, you know, the blood and guts of being in the emergency department? Or did I like kind of the more methodical process of being in the hospital, especially up in the ICU? And then I discovered that you could actually do both. So that was really my draw. I like that variety where I get to pick a little bit of both. I get to go downstairs and put a shoulder back in, suture up a laceration, get a corneal foreign body out. But then I also have time to go upstairs and think about, okay, this patient with really bad ARDS who's refractory, what else do I got? What other tricks do I have up my sleeve? So for me, at least, a lot of it's about having that variety of being able to practice in kind of two different two very different.
Absolutely. I love that perspective. I think that's one of the things that's mainly grasping people nowadays as well, is that you can actually practice in both environments. And, with the, I guess, development of these EDICUs as well, it's almost getting a little bit more exciting to not just work in either or environment, but work in, kind of this combined environment down in the ED. I know, Dr. Gordon, you work a little bit in the EDICU as well. Do you have any kind of comments and how that kind of comes into play in your job?
So let me answer your first question first about why medicine, because I think it can be helpful to people considering different pathways. So for me, I think it's two or maybe threefold, and honestly, I probably can't keep track of all the reasons, so I shouldn't give you a number first. But number one, I like the patient population. So I like the medical intensive care unit. I like the complexity of those patients. I like the nuance. To me, I say that there's usually never a right answer in critical care. And I find that is very liberating as someone who likes to be right. As long as there's no right, then it's okay. There's sometimes a wrong answer. And as long as you know the wrong answer and you don't do it, you're okay. But I really like the complexity of the patient that we take care of in the medical ICU. And then as far as fellowships go, the medicine pathway to fellowship really has more room for scholarly pursuit. The anesthesia pathway is a much more clinical pathway. And so if you want to build an academic career, especially if you want to work in a medical ICU, then the medical pathway to fellowship can make more sense. We can talk about that more if people have more questions. But I think that's one of the reasons that medicine pathway worked for me. Then the second question you have is, how does the EDICU work in my practice? And so that is really institution specific. And I think many of us work on the border of emergency medicine and the ICU by virtue of just our training, which is that we tend to be the bridge between these two places. And for some of us, our actual job is on that border. But I think that is a place for all of us exists because we really touch those places, even if it isn't specifically in our job description. And then for us at Stanford, we have a consultative model, although that's actually probably not exactly the right word. There are some really true consultative models of EDICU, but what we do is between Monday through Friday, between 2 and midnight, we have a dual EM intensivist, and we essentially function as a swing ICU attending. So the existing ICU attendings and MSICU sign out their patients to us. We manage existing ICU patients. And then we also take all new admissions, see new consults that come in at that time, and then go to codes. And there is a resource for both the fellows and the emergency department if there is a resuscitation or anyone wants basically an intensivist consultation. So that is how we bridge that gap, and that's how that works for me. I don't know if that answers your question.
Absolutely. Yeah, like you said, EDICUs just seem to be a very novel thing, but very institution specific, it seems like, as well. So great perspective. And thank you for the input on kind of your idea of why you chose the medical ICU as well. So Dr. Lentz, did you want to include anything as well?
Yeah, sure. So I also like the complexity of the medical ICU. I think when I started out in training, I had to figure out, did I want to do emergency medicine or something more? And I found I like the continuity. I know a lot of people in emergency medicine sort of beat us up for liking to round, but the continuity is a lot of fun. I feel like I really own my patients when I'm on service in the medical ICU. I get to follow them through their critical illness over 5 to 7 days, or depends on how long I'm on service, but they're really mine. I get to figure out the puzzle of what's going on, try to fix it, and try to guide the patient and the family through that experience. I also like the feeling of being a generalist still in the medical ICU. We can take care of a little bit of everything, and most everything lands in the medical ICU from time to time, even surgical patients. When patients are in the surgical ICU for too long, they tend to call the MICU to transfer them out for ongoing ventilator management and different things. So we tend to be able to manage a bit of everything, much like my job in the emergency department, where we can see and kind of begin to manage almost anything. So those are the things that I like the most about the medical ICU. And I still like the ED shifts, the quick fixes, but I also like the continuity and the complexity of the ICU.
Yeah, I definitely agree. I think a lot of the reasons that people choose to go into, MICU, SICU, et cetera, is because of the continuity of care. Seeing something in the emergency department to carrying it out and hopefully either discharging the patient or whatever the next phase of care is pretty neat to see. And so that's a great input. I love it. So next question is going to be kind of a general fellowship application cycle look. So I know that, between the various critical care specialties, there's different timelines that you follow in order to actually be successful in applying to the specialty for emergency medicine. Focusing on the MICU, I guess this time, what does the timeline look like for the fellowship application cycle? We can take the null third and fourth year out of it, but basically including your last year, what does that look, or your second year of emergency medicine, what does it look like when you're applying to it? Do you follow a certain template? Do you have to have certain things on your CV? And then what does the timeline look like?
I suppose I can take this one. So you'll apply to the medical critical care medicine fellowship in your last year of emergency medicine residency in the fall. We're actually doing interviews right now. And so you apply the fall of your last year, be it your third or fourth year. So that's the timeline. And we are now in a match. So it's a match process done through ERAS. So you apply to us through ERAS, you do interviews about now. And then you'll put in a rank list and then find out on match day. That was the first part of your question, I think, which is timeline. And so that, just to distinguish that from the anesthesia pathway, where you apply in the spring of your second to last year. So that's another good reason to do medicine pathway, which is that you decided later. So I think that is the particulars. Then I think you asked another question, which I'll maybe let Doctors Wu and Lentz answer, which is what should be on your CV, what should be in your application, what kinds of things are you looking for? What do you guys think?
Yeah, I mean, I think that's I think that definitely what I advise to medical students or to residents is, one is keep an open mind, at least for your first year, and then as they decide into their second year. At least in our program, we take our second years at the beginning of the year and take them aside and try to help them figure out what they want to do if they have an academic career in mind, to try to help them start building that going forward. What I tell the residents is having things like publications is always good. It will never hurt you, but no one ever expects people to do hardcore research. Residency is too busy and too short to be doing things like randomized control trials. But that doesn't mean that there's not enough time to be publishing things like case reports or review articles and things like EM Resident or Emergency Medicine, EP Monthly. These are great opportunities.
Like common sense.
Or common sense. Thank you. I was getting there. Be publishing there. So I definitely encourage residents who are thinking about academic careers, not just critical care, but thinking about fellowship, to be looking at those things. And medicine is also a little bit unusual in that there are requirements to have a certain amount of floor months and medical ICU months before you can start fellowship, or at least before you can supervise. And June, you were probably nearer to this process than I am, so you correct me if I'm wrong. But in general, you will need 6 months of medicine experience in order to supervise internal medicine residents in the medical ICU. That doesn't all have to be done by the time that you start your fellowship, but it does technically have to be done before you start supervising medical medicine residents, and that's an ACGME requirement. And that can trip people up if you're not reading the text carefully. So you have to have at least 3 medical ICU months and another 3 months of medicine experience. Unfortunately, things like surgical ICU, pediatric ICU don't count typically, but things like cardiac ICU will as a floor month, which is interesting, right? It's an ICU, but it counts as a floor.
Well,
and
it doesn't have to be floor specifically. It just has to be a month of medicine.
Right.
And so any medicine subspecialties count.
Yep.
Yeah.
No, thank you. That's a good clarification. So just keep that in mind. You got to count those beforehand. I would say that most residents have a hard time getting all 6 months beforehand, unless you are really, really good at planning and have a program that gives you a lot of elective time. It's frankly going to be impossible. But I do tell residents, try to get as many as you can. 4 is kind of a pretty good number to get. That doesn't mean that you can't start fellowship without all 6 months, but it does mean that you can't supervise the medicine residents until you've done those. That's one of the unique things about applying for medical ICU fellowships.
Yeah, I think some general advice. So I think I had 4 or 5 months before I started fellowship, and my first month of fellowship was on the nurse practitioner medical ICU service as the fellow. So that was the way that they counted it. So I think most programs are open to working through that with you, in my experience anyway.
Yeah.
The other general advice I would say is seek out mentorship. Find somebody in the field, get to know them, ask them their advice, because I think that really makes a difference. And shameless plug, but come to our section meetings, you'll meet 5, 6, 8 of us throughout the country that are doing this and are involved with fellowship programs in different capacities. So I think coming, asking us what's important, asking us where to look, where might meet our needs and interests, I think is a great way to get into this field.
No shame in plugging the CCMS, Dr. Lenz.
I would say another thing to call out, and I don't know if you guys feel this way, but I think the reality is the EM applicants are really strong and they are increasing in number. And so it's almost a blessing and a curse to want to do emergency medicine critical care at this time. The blessing is there are more and more of us. It's becoming more an understood pathway. There's more job opportunities, which is huge and a really, really big deal. But the curse is that you're competing against other applicants who are extraordinarily qualified. And programs are typically not going to fill with only EM applicants. Medicine, critical care medicine fellowships will not fill with only EM applicants. And so it's becoming increasingly important to distinguish yourself in some way as an EM person. And I think good mentorship is really the answer to that. Because you really, as a resident, as Dr. Wu says, you're really busy, and the idea of creating something novel from scratch is almost impossible. I say almost because somehow people do it, but really tagging on to existing projects can really make a big difference, and our group can be helpful with that too. But this is really an interesting time for emergency medicine critical care because we're seeing record numbers of applicants. And I would say, I don't know if this is true for you guys too, our applicants are exceedingly qualified.
Yeah, I'm not sure I would get a fellowship in this day and age. I think I've been passed over pretty quick.
Same.
Yeah, I think it probably speaks to the people that are interested in doing this, committing 2 more years of their lives to training, are really motivated to do it. So I probably self-selected a bit too, but yeah, ask for help along the way.
Great, thanks guys. So just kind of delving into the next question here. I'm kind of going through these a little quick because I want to get to kind of the understanding of how the day-to-day activities are for the MICU through a case. But the next, I guess, question we have is, how does the MICU subspecialty differ distinctly from the other 4 critical care pathways that, an emergency medicine resident can take, that being resuscitation, SICU, anesthesia, and then neurocritical care as well?
I'll take a stab at that. I mean, I think one of the key distinguishing hallmarks is by the end of your fellowship and once your critical care medicine boarded, that depending on the institution, that may or may not give you privileges to work in the medical ICU. And for most academic medical ICUs, these are owned and run by the pulmonary critical care division, who are traditionally have been more open to critical care medicine than other critical care specialties. Historically, other ICUs, things like surgical ICU, cardiac surgery ICU, have been made up of more multidisciplinary pathways. But medical ICU has sort of remained relatively strict in terms of who will take. And that doesn't mean that that exceptions don't exist. I can tell you where I did fellowship at Brigham, we had 2 nephrology intensivists, 3 infectious disease intensivists, and 1 EM medical intensivist. But the majority of it was pulmonary critical care. And that's one of the things that most critical care medicine programs do have a lot of overlap, is that you do mingle a lot in the pulmonary side, and you get to know them pretty well. But that's one unique thing about medical ICU is it's a relatively narrow set of people who are typically privileged to work there.
I'd say the other big thing is ownership over the patients. I think almost every medical ICU is a closed ICU, which means that when they're admitted to the ICU, they're admitted to one of the intensivists. So if I admit a patient when I'm on service, I'm their attending of record, they're my patient until I leave service and hand them off to someone else. The surgical world's not necessarily like that. Usually the surgeon admits them and then consults you as a surgical intensivist is often how that world works in my experience. So it's a little bit different of a feel. You're kind of co-managing rather than managing as the primary attending or primary team. So I kind of like having that ownership. I consult people, I ask their opinion, I ask for help often, but at the end of the day, they're mine, my patient to manage. So each comes with their plus and minus, but that's one thing I like about the medical side of it. I'm interested to hear Greg's. You mentioned resuscitation fellowship. I'm interested to hear Greg's opinion on that a little bit more. I think in my mind, the biggest difference is the resuscitation fellowship trains you to be really good at resuscitating in the ED, but you generally are not working in the inpatient world at all. And one of the things I really love is actually being in the inpatient side of medicine. I get to know a different side of the hospital. I get to know a whole different set of colleagues. And develop really, really different relationships with the hospital in general when you're on the inside, so to speak. As compared to the ED, you kind of feel like you're in the basement and an outsider in some kind of way. But those are my thoughts.
Yeah, it's interesting is that we've discovered there are actually more and more resus programs coming online. It's becoming it's definitely one of the hot growing fields right now. I will tell you that every program is a little bit different, but in general, our resuscitation is almost like a generalist. Is that just like in an emergency department, there's no such thing as a medical emergency department or a surgical emergency department or a cardiac surgery or a cardiac emergency department. It's just the emergency department. You treat what's in front of you and whatever comes your way. And a lot of resuscitation programs are oriented around that way of still taking that undifferentiated patient or that multidisciplinary patient and providing really good early critical care. Unless you're at a place that has a dedicated EDICU, there's not really a big inpatient component. Although it's interesting as how EDICUs have worked is that it creates an inpatient status for a number of logistic and billing purposes, but in regards, it's still very much kind of emergency medicine in that regard. What I tell, when people interview with us, they ask, what should I do, medical ICU or emergency medicine or resus fellowship based in emergency department? I tell them, kind of figure out what do you want your career, what do you want your day-to-day life to look like? Do you want to come around to the ICU? And take care of complex medical patients? Or are you more interested in kind of the more general care, less on the rounding, but having kind of that critical care skill set that comes with? And it's a little bit of a philosophical and practice difference that I think that really helps people distinguish about what they want to do going forward. And that doesn't also mean that you can't do both. There are definitely people who've done a resus fellowship and then decided, you know what? I want to go back upstairs. They go back and do a second fellowship or a third fellowship. It's a lot of time, but I think for them that it was the experience they wanted.
I do think it's pretty important to point out that these guys are answering the question to what does your life look like if you work in the medical ICU? And I think aside from resus fellowships, that's not the same answer as what does your life look like if you do a medicine, critical care medicine fellowship. Those are actually not equivalent. And many of us go into doing a medicine, critical care medicine fellowship because we want to work in a medical ICU. And so actually that answer is the same. But we graduate fellows every year that work in SICUs and CVICUs, especially our EM fellows, actually can usually go on from being medicine boarded to working in any ICU. That's actually, it's pretty institution specific if they have a preference, but really we can send fellows anywhere. So I think those answers are specific to what's your life look like if you work in the medicine ICU, but not what does your life look like if you do a medicine, critical care medicine fellowship. Did that make sense? Okay.
That's a really good point.
Yeah, absolutely. Thanks for the input, guys. That's good. It took a tangent, and I love the tangents that develop out of our discussions. So that's great. Last question before we get to the case here is just a very general. What does the future hold for the MICU subspecialty? Is it going in a certain direction? Is it staying the same? Whatever you guys can come up with.
Gosh, I feel like I just figured out what this job looks like now. I mean, I think that I will fully admit that I'm only a few years into this, but definitely the trend that I've seen since I started training and where I sit right now is increasingly multidisciplinary and cross-trained people. For example, we are graduating our second class of nephrology critical care fellows who are going to go on and be a nephrology intensivist. And I think, that was incredibly rare, but that's becoming increasingly a common thing. And I think that's done out of two reasons. One, that is done out of demand, just like there are work shortages in nurses. There's also a work shortage in critical care physicians. And it can't be just managed by our current training paradigms. We're seeing more and more multidisciplinary people. And I think that's going to be actually sort of interesting because emergency medicine stands to benefit from this as well, as more EM graduates want to go into critical care. So I think that's going to be interesting, where there's going to be someday an ICU where it's all sorts of people who have various backgrounds approaching these patients from slightly different perspectives and kind of bringing a different expertise, but all with that sort of critical care focus.
Yeah, I totally agree with that. I have this, I think it's maybe my personal bias, but I look at critical care as multidisciplinary. And I think it's at its best when we have multidisciplinary training throughout. So, I mean, there's always been some discussion about, should we just have a general critical care training pathway, a general critical care exam, particularly for those of us that are EM, like why do we have anesthesia and surgical and medicine when we do very similar things? So I don't know, perhaps in the future, there'll be a single common pathway where you get training in medical ICUs, surgical ICUs, cardiac ICUs, trauma ICUs. And at the end, you come out an intensivist and you decide where you want to work and you're really well-rounded. That's what I don't know. I guess that's maybe my dream, but if I could design it, but others may not feel that way. But I do think that multidisciplinary is probably the best training pathway to do. And I hope to see it be more common in the future.
Come do fellowship at Stanford then. Taylor, do another fellowship because we will train you in medical ICU, surgical ICU, CVICU, SICU, neuro ICU. You'll be so happy.
Perfect. No, I went to a very multidisciplinary training program, and I feel better off for it. I'm glad that I did
Totally.
do that.
Yeah.
Totally.
Yeah. Yeah. No, I purposely actually picked my fellowship because I actually wanted to do. I thought I might want to do burn medicine. So I actually had. I look back and figured 6.5 months of burn ICU in my fellowship training. And it was enough to realize that that's not actually what I want to do in life. But it is interesting to kind of apply some of those principles that you pick up along the way and say, all right, probably we should stop giving fluids.
I think that in the way that emergency medicine critical care is as a bridge and basically breaking down boundaries, I think that we actually are like symbolic of what the future of this specialty is, in the sense that people will go more places and people from different backgrounds will do more and do more different things, and things pop up on the transitions of care in different and interesting ways. And one of those transitions of care is from the ED to the ICU, but it's actually not the only one, right? It's from other hospitals, and it's from the OR to the ICU, and there's actually all sorts of transitions of care. And I think that we'll see even further subspecialization of the subspecialties and further focus on those different transitions.
Absolutely. Great opinions. I think, yeah, the future of the MICU is very exciting because every institution is completely different, as we'll find out with the next kind of case-based question. But I guess getting to that case now, it's going to be a very open-ended question. And I think we all realize that every institution has their own little niche as to what their, MICU attendings or specialists will actually do when it comes to either a transfer to the emergency department or maintaining, a critical care patient in the emergency department. So if we go with a general case of a sepsis patient or a septic shock patient comes into the emergency department, I honestly just want to get all of your opinions. What does your job look like when that patient comes in? Are you the one who's primarily managing that patient when they come in? Is it you and the emergency medicine physician? Are you transferring care? Is there an ED-ICU development that takes care of them? I just want to know from each of the three of you, like what would you do to manage that patient, and what does the flow of that care look like at your respective institutions? Tough question.
Well, I can tell you that this will be highly institution specific, and it's almost a little bit practice provider specific too. But in general, what happens is when we have a critically ill patient who needs to come in, the ED team obviously is the first one to see them first and start resuscitation, start getting things that need to get done. At my shop, we have a ED critical care consult attending and fellow, who's a resus fellow, who gets involved kind of after the initial resuscitation, or if the initial resuscitation is complicated and prolonged. And the goal is, while the patient's waiting in the emergency department, to keep the critical care management going. The medical ICU here typically does not come down to the emergency department unless we are specifically asked. That's done out of recognition that the medical ICU is kind of a busy place, so we try to cohort our patients together and trust our colleagues and other ICUs to help take care of patients. But certainly, we will all come down if asked. I came down last week when there was a patient who was basically impossible to ventilate and oxygenate, and that's sort of the nightmare scenario on an event where nothing is working, and now you have to start troubleshooting what else you got. And I came down and we started some inhaled epoprostenol, and that made the patient's numbers all better. And it's amazing. And suddenly, we dropped an ICU bed dropped, and we were able to get the patient upstairs. But I think certainly all of us are willing to come down and help if asked. That's just the flow of our institution. I also personally tend to stop by in the afternoon if there's a patient who's been boarding for a while and just ask the ED folks, do you want help? Do you have questions? Is there something we can do? Or I can advise on to say, hey, maybe you want to start this or stop doing that. Usually the answer is stop giving fluids to try to help patients care while they're waiting for an ICU bed.
Ours is very different than that. I don't know, Dr. Lentz, if yours is more the same if you want to go next, or is yours also super duper different?
A little bit different.
Okay, you want to go next if yours is a little, okay. So ours is very, very different. So if a critically ill patient comes into the ED, so you said a septic shock patient. So a patient comes in septic shock, the ED does the initial resuscitation, and then at which point they decide that the patient needs ICU admission, then they call us. And So an ICU fellow will come down and assess the patient. And the fellow will see if they think the patient needs the ICU. Typically, the answer is yes. If the ED thinks the patient needs the ICU, the fellow also thinks the patient needs the ICU. Occasionally, there are disagreements. Our fellow will then staff with an ICU attending. And then once we accept the patient to the ICU, we actually take over management of that patient. So even when the patient is in the ED, the ICU team is managing that patient. We have it staffed, the triage fellow and the triage attending, to be able to do that. And like we said before, the hours of 2 to midnight, Monday through Friday, that triage attending is always an ED intensivist. And so our ICU team takes over at time of acceptance of the patient. And so we actually don't have a terrible boarding of ICU patient problem here, but we have gone through times where patients are boarding in the ED, but we care for them as the ICU team from upstairs. I don't know how yours looks.
Yeah, ours is pretty similar. I'll say I take your question in two different ways. One is, what if I'm in the ED working an ED shift and I manage a patient like that? I think I probably approach it a little bit different than my emergency medicine colleagues. I don't mind managing that patient for longer than they do. I would say general culture is, as soon as pressors are started, as soon as they're intubated, we get a phone call in the ICU, I've got a patient for you, which is fine. That's what we do. Disposition time makes a difference, but I'll generally manage people pretty aggressively and try to figure it out. Like, I sort of just have to figure it out. What's wrong with this person? What's the source of their infection? What's the next step? What's source control? Can I get them off pressors in 2 hours? Can I, what do I need to do to stabilize them and begin really optimizing their first couple hours of management if I'm on the ED side of things? I think our system is very much like June's, that the ED will call us if somebody is on pressors or they think they need the ICU, and the fellow receives that phone call primarily. And then the fellow will decide, yeah, we'll accept, I'll be right down and come take a look at him. But the fellow usually sees most patients prior to admission. And then usually when we accept them, we kind of co-manage in the sense that we kind of can begin to write orders. We generally don't have a boarding problem, but questions will begin coming to us, and then we can start managing them, understanding that the ED team is right there should they get much sicker and intervene. But oftentimes, once we accept, we begin to take over their care to the best of our capability, depending on how available and busy we are upstairs.
Yeah, great perspectives. I think that's one of the most important questions that, people that are considering going into this field is, what does my job look like from start to finish, and managing that type of patient in the ED, I imagine, is pretty exciting, but also the transition of care to an ICU and actually seeing them hopefully walk out the door is also just as exciting as that. I guess one of the last questions, we typically have is there more camaraderie between you and the emergency department, knowing that you've been EM trained versus another specialty? Is there more respect? Do they, respect your opinion a little bit more than that of other people?
I would say in my circumstance, I hope so. I work half my time in the emergency department. I do shifts with my EM colleagues. I'm an emergency physician just like they are on those shifts. So I hope so. In that regard, I feel like I'm a colleague much differently than my pulmonary critical care or more ICU only colleagues are. So I do think so. And I would imagine that's true even if I didn't work ED shifts, though. Working in the ED is hugely beneficial because I know the nurses by name, I know the techs, I know the pharmacists, I know the respiratory therapists, I just know the environment, I know the people. So it makes it much easier, I think, for me to come down there as the admitting attending. So it's, I don't know. I don't know if Greg and June, do you work ED shifts typically? I don't know how it changes if you didn't work just general ED shifts, if the perspective is different.
Yeah, I mean, I just still do ED shifts. I'm more ICU these days due to kind of a series of buy downs and various incentives, but I agree. I do find it useful to be knowing what's going on, who's down there. I definitely think that my colleagues respect my opinion, or at least they tell me they do. Maybe they don't. They just haven't told me that yet. and I feel like it ends up being more of a, I think they feel a much lower threshold to call me and ask me for help or for my opinion on something than they might otherwise. In part because they know they're not waking up, they're not paging me, they're just calling me on my cell. And I think for them that's a lot lower activation energy. So I think it's definitely very, very beneficial. The other thing I think is actually really helpful is I feel like that actually keeps my hand in the emergency department. I also get to teach my EM residents critical care skills. I can tell you that most of my EM residents have not put in, say, small bore pigtail chest tubes, but they will definitely do it with me and do thoracenteses with me. And then my pulmonary critical care and nephrology critical care fellows are learning how to do like nasal packing and like rhino rockets for like uncontrolled epistaxis, and it's not typically part of their training as well. And I think that's kind of a neat thing to actually kind of have to say, I can teach you both very interesting things that are that you will find useful, but are not typically things that you're going to learn.
I also think it's incredibly important that we know what it's like to be an emergency physician, right? I actually don't work any general ED shifts, although it's different because I trained at the institution that I work. So like, that's my family. They raised me. And so I think it's totally different. And for, you know, I'm hired by the emergency department. So that's like genuinely my home, even though I don't work general ED shifts. But we know what it's like. We know the stresses, we know the challenges, we know the skill set. So I think that really helps us. And that's actually true in both places, right? And that's another one of those times where we talk about how we're the bridge, right? We really understand the same language and the same struggles. And so I think that can make it really useful and helpful for us because we've been there.
Absolutely, great input, and yeah, it's very interesting to see even at my own shop here the differences between having someone who's emergency medicine trained versus someone who has another subspecialty under their belt, and I guess the camaraderie that exists between the emergency department and those specialists. So it's nice to just be able to call them or text them and be like, hey, I just need your help with something. So that's pretty much all the questions that I wanted to ask you guys. I wanted to leave at least 15 minutes for open questions for the audience, and I'll give it a good 10 awkward seconds before I cut anyone off. So if there's any questions in the audience, please go ahead. Great, that was an awesome 10 awkward seconds. So that's perfect. Do the panelists have any last comments that they wanted to include before we finish up this second part of the critical care series?
I think from me, just thank you so much for moderating and doing a brilliant job as always, and reminding people to come to our meeting. It's a great place to be as a trainee and to get involved and learn what we're doing and meet great people.
Yeah, no, definitely. This is I love these questions. These were those are a great session. I definitely encourage folks too, is that even if they're thinking about doing critical care, it's never too early just to reach out and just ask. Because even if you find that you don't want to do it, it's better to. I'm a big believer in try early, fail early, and try again. So don't feel like you need to wait for the perfect opportunity. If the answer is try things now.
Yeah, I agree with all that great advice. I think reach out early, come to our section meetings. If you don't have any mentors in-house, we're happy to help.
Absolutely. So just in finishing up things before we kick everyone off, please attend our monthly council membership meetings for the CCMS. They take place at 7 p.m. Central Time, 8 p.m. Eastern Time, the first Thursday of every month. And you can find the email link or the Zoom link for that on my AAEM as well. If you don't receive IEM emails, you can contact our amazing Kathy Yu at AAEM, and she'll be more than happy to send you the notification and the invite for that as well. And if you're not a member of our section, please join. We are an awesome section, one of the largest sections, and very active section as well. To mention some of the things that we have coming up, we have the CCMS Barvello competition at AEM 23, which we want people to submit all of their amazing things to that. We also have our second iteration of the Introduction to Critical Care and Emergency Medicine course, starting applications in November. And then our third iteration of the Pathways to Critical Care series will focus on the SICU in November. So please look out for all of that awesome stuff coming up with the section, and come and take part at our next one, the first Thursday of next month. Otherwise, thank you very much for our panelists for speaking and taking the time to spend our night talking to all of the attendees here. So appreciate it as always.